Okay. Welcome to today's Measures Management System information session entitled Advancing Age-Friendly Care from the 4Ms framework to the CMS Inpatient Quality Measure. Next slide, please. So there will be a Q&A session at the end of this presentation where we will answer all audience questions. You're able to submit your questions using the Zoom Q&A function. So just feel free to submit questions throughout the presentation, and we will do our best to get to as many in-scope questions as we get at the end of the session. And if your question isn't answered during the Q&A, we'll be posting FAQs to the MMS Hub website in a few weeks. Let's go to the next slide. And so this is just showing you where to access that Zoom Q&A function. So you'll see a little Q&A button at the bottom ribbon of the Zoom window. And so when you just open that up, you can type your question into the question box and hit submit. And we can move to our next slide. And the next one. Okay, so we've got several objectives for today's webinar. By the end of the session, participants will be able to describe the development and domains of the age-friendly health systems 4Ms framework, explain the alignment between the 4Ms framework and the new CMS Inpatient Quality Measure for age-friendly care, and examine how Luminous Health implemented the 4Ms framework, identifying practical strategies and lessons for the new CMS age-friendly measure. Let's go to the next slide. So we've got a wonderful panel of presenters today. And so I'm going to kick it over to our first panelist, Kellyanne Johnson. Kellyanne, over to you.
Thank you so much. And it is such a privilege to be with you all today. My name is Kellyanne Johnson. I'm a Senior Director for the Age-Friendly Health Systems Movement at the Institute for Healthcare Improvement, which is a not-for-profit based here in the United States, working all around the world on improving health and healthcare. And we have an incredible panel with us today that will help advance those objectives that we just heard. And we're really privileged to have with us to kick us off Ronnie Snyder, who is Acting President and Vice President of Program at the Johnny Hartford Foundation, which she'll share a little bit more about. It's a private philanthropy dedicated to improving the care of older adults. And Ronnie has been an incredible strategic leader in setting the agenda for the age-friendly health systems movement and getting us where we are today. And Ronnie, to set the stage, can you walk us through the origins of the age-friendly health systems movement and how it has evolved into the national and now policy relevant effort that it is? Why is this a pivotal moment for age-friendly care in the United States?
Thanks, Kellyanne. I would love to do that. Thank you for asking. Let's see. I'm going to talk first just a little bit about the Johnny Hartford Foundation. As Kellyanne mentioned, our mission is to improve the care of older adults. You can see that here. And we've been engaged in this work since 1982 is when we started our work in aging. And since that time, all of our grants total about $737 million. So I can't wait till we get to that $1 billion mark. But that speaks to the longevity not only of aging and the people in our communities, but also of our work. We work really hard to be a catalyst for change. We do that through collaboration, in this case today, with folks from the Institute for Healthcare Improvement, our grantees and partners, as well as others in the field. Maybe that's Battelle, maybe that's CMS. In this case, we really work with all of the partners who we can engage to work on improving care for older people. And that kind of collaboration is very much in our DNA. I'll also add that all of the work that we do tries to have a lens towards removing disparities everywhere possible. So as you can see in this diagram, we view our three programmatic areas as interconnected and overlapping. Next slide, please. Okay, so when we think about this, it's really a why do we need age-friendly care? And the most obvious answer that I think people come to first is the sheer demography of what's happening in our communities right now. And quite frankly, not just in our country, but internationally. The increasing number of older people is rapidly growing, is increasingly diverse. And maybe less clear to some folks is the increasing complexity as well of the needs of older adults. So as we age, we're more likely to have multiple chronic conditions, things like dementia or are conditions and diseases that come with age specifically and other forms of disability. Also, people are more likely to be isolated as they age, as are their caregivers sometimes. And there are a variety of social drivers of health that feed into any of those things. And then last but not least, the possibility for disproportionate harm that happens more for older adults than for other age populations. So higher rates of those healthcare related harms, the discoordination of care when there are multiple issues or multiple different conditions, and then of course in a public health sense, poor preparation for disasters. Next slide, please. So we started this work in 2016 when our president, Terry Fulmer, came in. That's when we launched what we now call the Age-Friendly Health Systems Movement. At that time, there were multiple models of care. You can see 17 listed here in a variety of different kinds of settings. And our foundation decided that those settings were too scattered and not uniform enough, as were those models. So we convened the Institute for Healthcare Improvement as our partner, a whole set of experts in geriatrics, the model creators, for example, health systems, and others like the American Hospital Association to identify the core elements that would be needed to improve health outcomes for older people. That is how we came to what we now call the 4Ms and the age-friendly health systems movement itself. So next slide, please. And here's the result. The result is age-friendly health systems. And it is a framework really for care that is intended to build a movement so that all care for all adults, anywhere that they receive care, we often say from the kitchen table out to any site of care and back home, is equitable and it's age-friendly. It is guided by an essential set of evidence-based practices. Those are the 4Ms that come from all of those models of care. It is designed to cause no harm. And it is consistent with ultimately what matters most to older people and their family and their caregivers. And you can see here, just from this this visual, that what matters is at the top, and that all 4 of these M's are designed to come as a set. So medications, mentation, which is anything cognitive, and mobility. Next slide, please. We're really excited. We're actually very proud of the rapid spread to hospitals, ambulatory practices, nursing homes, convenient care clinics, FQHCs all over the place. And quite frankly, this number is already out of date. The most recent number I saw from the month of July is over 5,300. So it's constantly changing and growing. And you can see we've got a lot of work to do, but there's a lot of dots on this image. So now I'm going to turn to the next slide, please. The age-friendly hospital measure, which is really what we're here to talk about today, which was built very much on those 4Ms and the concepts behind those 4Ms of age-friendly care. You're going to hear more about the domains later, but here I want to draw out the ways that the domains themselves within this age-friendly hospital measure match to the 4Ms. And I'll just say on the top side that this measure is a clear signal to hospitals that CMS is serious about population-based care for older people and is committed to adding measurement to that. This is incredibly important. The measure itself shows that hospital commitment to improving care for people who are 65 or older, who are receiving services in the hospital, whether that means the operating room, the emergency department, or elsewhere in the hospital, ultimately have to best respond to older people. I want to note here that I'm talking about 4Ms and the age-friendly health systems movement, and there are two other programs that also help hospitals get to these 4Ms. They are the geriatric surgery verification through the American College of Surgeons and the geriatric emergency department accreditation available through the American College of Emergency Physicians. So I'm not going to go through all of these 4Ms because you're going to hear more about it, but I do want to note the ways that the different domains, these 5 domains of the measure, match with the 4Ms, and you'll see them noted here in blue. You've got what matters, and that's very much about goals of care. You've got medications, mentation and mobility, both within the frailty screenings. And I do want to also note that with that last bullet around age-friendly care leaders, we have found in all of our work that you've got to have champions on board who are doing this work, who are driving this work. So we're really grateful that that's a part of this measure as well. Each domain is scored, and the domain gets a point only if all questions are attested positively. So the original measure developer, although this again, back to that collaboration in our DNA, we IHI, ASAP have been a part of it, but I do want to give full credit to the American College of Surgeons where this was initiated originally. I also want to note that data collected will be publicly available on the Medicare Care Compare, which is really important because that's where hospitals show publicly what they're up to and what we should be looking at. And so any of the 3 initiatives I just mentioned, the age-friendly health systems movement, the GERI-ED work, as we call it, and the geriatric surgery work, can help hospitals meet the measure. So I just want to end on this slide by saying there's a true opportunity here. There's an opportunity in and around hospitals that we're talking about today. And given the reception that this measure has received thus far, there's an opportunity for the field to go beyond what's already been done, to go beyond this current attestation measure and beyond hospitals to evolve and really make this measure reflect what's important in the moral imperative that it is to take care of older people in our society.
Thank you so much, Ronnie. And thank you for setting incredible grounding and really calling us all to meet this moment, to address this measure, but to go beyond really in the interest of supporting older adults who deserve this high quality care. It is my honor now to introduce Dr. Katie Drago. And if you go to the next slide, just to set us up, she is the medical director and Director of Quality with Marquee, a post-acute and long-term care group based in Portland, Oregon. She is also faculty at the Institute for Healthcare Improvement, working with age-friendly health system efforts, both nationally and internationally. And she is a seasoned interprofessional educator with the Oregon Geriatrics Workforce Enhancement Program. And she previously ran the inpatient geriatrics program at the Oregon Health and Science University Hospital, which some of that experience she'll call upon today. And I am really interested, Katie, in what makes the 4Ms framework uniquely effective as an approach to age-friendly care, and to expand on what Ronnie was already sharing about how does the new CMS inpatient quality measure align with the 4Ms?
Well, thank you for having me, Kellyanne, and the staff at Battelle and CMS. It's always a delight when I get to go around and talk about a passion project of mine, which is age-friendly health systems. Ronnie is also a very hard act to follow, so please judge accordingly. The 4Ms, what really is magic about the 4Ms is that these areas, and you can see a bit more description, a bit more detail into the definition and really the core essence of each M here on the slide. All four of these areas are backed by decades of very well established good science in the field of aging, care for older adults, and programmatic interventions, health system based interventions to support successful aging and healthy aging. So, all of these concepts, all of these areas and foci of care are not fringy by any stretch of the imagination. Those of you that have done clinical work, that still do clinical work, that care for older adults, I imagine every one of you is looking at this list and saying, yep, yep, yep. Because these areas really do make up a core set of pillars for healthy aging, getting through illness and injury with as few fireworks as possible, and really success in the last chapters of life. Next slide, please. So why the 4Ms? Because these make up the core of my profession as a geriatrician, and all of us, regardless of our discipline, when we care for older adults. So these ideas are built, again, on decades of really good science that, that has demonstrated that these areas, aligning care with what's important to the patient and their trusted circle, using medications that advance those goals without detracting or creating more complications, maintaining mobility, independence, and function through all the stages of health and life, and then attending to depression, dementia, and delirium across the spectrum and across the settings of care are not just good practice on their own, but they are also heavily intertwined with each other. What's also, I think, a little bit of magic about these 4Ms is that they are synergistic. You cannot disentangle one of the M's completely from the other three or two from the other two. It is impossible because medications are always going to have impacts on mobility. And vice versa. Think about your diabetic patient who has neuropathy in their fingers or becomes blind. So their function, managing their medications becomes different, right? And their care needs become different. You cannot disentangle mentation, things like depression, from mobility and what matters. And then what matters, of course, drives all the other three, the way we attend to those areas of health and life. So this too is really different. I'm sure a lot of you have seen in your roles different initiatives and quality practices and regulatory measures and all sorts of things come and maybe go or evolve over time. This is different in my practice, different from much of what has come before, because it really does tap into that core essence of what it takes to successfully care for an older adult or someone who's aging, and really touches on the fact that everything is intertwined when you're dealing with older adults, their caregivers, and their environment. Next slide, please. And what we're starting to see is this work put into practice and really starting to see the fruit of a model, an improvement model that really does attend to those core features of what it takes to care for older adults and the fact that they are all intertwined with each other. This is just a quick snapshot of a growing body of evidence that is out in the published literature looking at the impact of health system adoption and reliable use of all 4Ms. You can see up here top right hand side, this is a great study from, I believe, the VA in Boston, looking at, after they implemented and stood up their 4Ms and age-friendly program, what they saw in terms of utilization outcomes for their post-acute rehab and then long-term care through the VA CLC. And these numbers are huge when you're talking about post-acute care and long-term care utilization. I know I work in post-acute and long-term care now, and when I see a 73% decrease in ED utilization amongst long-term care residents, that will always get my attention. And then on the bottom left there, this is actually work from my former role at OHSU. We wanted to look at the impact of receiving 4Ms care during the admission and what impact, if any, it had on the days spent at home after, in the 30 and 90 days after discharge, because we know what happens in the hospital does not stay in the hospital. And what we saw was that at a tipping point of 3 of 4 M's during the hospital stay, those patients that received 3 or 4 M's during their admission actually spent significantly fewer days in an emergency room, a hospital, or a post-acute rehab within those first 30 days after hospital discharge. I don't know about you, after working in a hospital for 10 years, I have never met a single patient, regardless of age, that would voluntarily choose to come back to a hospital when they had just been there. So this is an incredibly patient-centered outcome, and one that really proves what I think we have known all along, which is the 4 M's really do have a ripple effect. They have resonance beyond just the day or the visit that they receive that kind of care. Next slide, please. This is work that we just found out yesterday is going to be published in the Joint Commission Journal for Quality and Patient Safety, so should be available in the next few months. This is also from my time at OHSU. We wanted to look at amongst our inpatients who were receiving, or exposed at least, to our 4 M's care during the admission. By September, or by 2023, we look back and we realized we had a critical mass of about 13,000, almost 400 hospital admissions amongst patients over the age of 65 years of age, was just under 11,000 unique patients. Some poor folks had the misfortune of being admitted more than once, which is an opportunity, extra opportunity for us to deliver 4 M's care. We took that cohort of admissions, split them up into 2 piles, one where the recipients got all 4 M's as we define them during their stay, and then everyone else that received 0, 1, 2, or 3 during their stay. And the reason for that, again, is that the 4 M's are synergistic. There is something magic that happens when attention is paid to all 4. And we really wanted to pull that out, that impact out of this work. And what we were most interested in looking at is the juicy measures that your bosses and my bosses care about, which is overall length of stay, time in an ICU, of which we had 4 at OHSU, so a lot of ICU beds. Total charges, so what we charge payers like Medicare, Medicaid, and other third parties for our care, not necessarily what we were reimbursed. And then 30-day readmissions, which we know is a huge, huge issue across the country. We adjusted for all the covariates of interest that can create some noise in this data. This is very complex, very juicy data. We also did some propensity risk score matching, which is just designed to further eliminate any noise by trying to compare apples to apples in terms of patient demographics and clinical characteristics as much as possible. And then we were able to stratify by case mix index, which is a measure of how complex the hospital stay was. So this includes both significant chronic conditions as well as big time acute conditions like sepsis or respiratory failure, and in a kind of risk adjusted number. And we were able to divide out those sicker sick compared to those less sick during their stay. So let's see what happened. Next slide, please. So here's what happened. Over those 2 years, almost 14,000 admissions. In the second, you'll see the outcomes of interest listed on the far left-hand side. The second column is just the apples to apples comparison with all the adjustment and propensity risk score matching. But I really want to call your attention to the third column, which says high CMI. Excuse me. Whew. High CMI, and these are those sicker sick inpatients. And what we did is we took the top of the bell curve. So the cut point for high versus low is a case mix index of 2. For context, the average at OHSU for all ICU patients is a case mix index of 4. So a case mix index of 2 is pretty much your standard, in a tertiary care academic medical center, your standard ward patient. So not truly that sick when we come to think about it. But it turns out if you have a case mix index higher than 2 at OHSU, you actually get disproportionately more benefit in terms of utilization. These patients saw a greater decrease in total charges. They saw a 1 full day length of stay reduction, which is eye-popping and mind-boggling for those that work in hospital care. A 2/3 of a day's reduction in the ICU, which is a difference between being able to turn over that ICU bed at 4 o'clock in the afternoon compared to 8 o'clock in the morning, which has huge impact for things like planned major surgeries for patients that are expected to need a critical care bed afterwards. And it was these patients that had the more complex, sort of sick admission that actually saw any benefit whatsoever in a reduction in 30-day readmissions, which was really surprising, right? One, it sort of stands to reason that these patients are going to be the most vulnerable to having more expensive care, spending longer in places, and returning, getting caught up in that revolving door back to the hospital. But it turns out the 4Ms is actually a very effective intervention to break that cycle for these patients, of which most of us working in acute care are seeing more and more of these sort of sick inpatients and more complex stays. So there is juice in this lemon to be squeezed, that the 4Ms as a model, as a conceptual model of care, and then all the way down to the actionable granular activity can make a huge difference for patients, but also for health systems, for payers, for staff, for all of us that interact in this very complex wheel. I think this is my last slide. So next slide, please. Oh, here's the domain. This is actually my last slide. Here we're looking at the different domains, not necessarily the statements. There are, like for measure 3, measure 4, and measure 5, there are multiple attestation statements underneath. But this is a high-level crosswalk to see that the CMS measure developers actually really took this 4Ms framework and they ran with it. Because the 4Ms actually show up throughout all 5 domain measures. The increasing importance nationwide, starting back in the late teens and 2020, that all of us are now putting on social determinants of health, social vulnerability, the intersection of things like food insecurity, transportation insufficiency, other impacts that really impact the patient's ability maybe to benefit most from 4Ms care also shows up here, which is really forward-looking. And then Ronnie mentioned the fact too that no institution or setting of care or unit or team that has been on an age-friendly journey has been able to achieve success without a leadership structure to help support and guide their efforts. And I think the CMS measure not only includes the 4Ms content, but it also includes these 2 additional incredibly important facets of the environment and the context in which we work that have been really key to success. So for those who have not been on an age-friendly journey just yet, I welcome you to the family, and know that all of us at IHI and Johnny Hartford are here to support you as you go through aligning with the measure, but hopefully deciding to become age-friendly participants and really joining us on the journey. Thank you.
Thank you so much, Dr. Drago. What an incredible overview of how the 4Ms have been impactful for you as a practitioner, and how you've gone about your work and both the impact that they've had in your health system. And it is my pleasure now on the next slide to introduce another wonderful panelist, Dr. Ivy Mwangi, who is a geriatric hospitalist at the Anne Arundel Medical Center in Annapolis, Maryland. Her clinical focus is the care of hospitalized older adults with special interests in implementing age-friendly care. And she is also faculty with the Institute for Healthcare Improvement, supporting hospitals in their implementation journeys. And so, Dr. Mwangi, I want to point out that Luminous Health and particularly the Anne Arundel Medical Center have been real leaders in implementing the 4Ms of age-friendly care. They were pioneers in testing the 4Ms when we were doing some of the work that Ronnie described earlier. Could you share more about your hospital's journey and fill us in on which practical strategies have been most effective in embedding the 4Ms into clinical workflows? And as you can imagine, I'm especially curious about how those strategies will support hospitals in their readiness for attesting yes to the CMS measure.
Thank you so much, Kelly, for the introduction and for the invitation to share at this forum the Luminous Health experience in implementing the 4Ms framework and now applying it to the CMS Inpatient Quality Measure that was announced last fall. So by way of introduction, the Luminous Health has 2 hospitals in the state of Maryland, Anne Arundel Medical Center, which is located in Anne Arundel County, and Doctors Community Hospital in Prince George's County. Of interest is that the Anne Arundel Medical Center Emergency Department is one of the busiest in the state of Maryland, with over 1.4 million ED visits. In the last 1 year, we have also seen over 30,000 older adults over the age of 65 present to our emergency department, a large proportion of whom present from surrounding skilled nursing facilities and assisted living facilities, in addition to those coming from home. And so the age-friendly care is very important and relevant to our day-to-day practice at the Anne Arundel Medical Center, just given the population of adults over the age 65 that we are seeing. Next slide, please. As you've heard, our age-friendly health system journey started a few years ago now, over 10 years ago, in 2013, when an acute care for elderly unit was opened in the acute care hospital at Anne Arundel, supported by private donors at the time. Next. We then were invited to join the first facilities that were awarded the John A. Hartford Grant to work on becoming age-friendly health systems. And we got our level 2 recognition in 2019. Next. Following that, next please, we had our geriatric ED accreditation, level 3, which is the bronze level, and we are continuing to work on achieving the level 2 and subsequent level 1 with our emergency department, which, as I have noted, is one of the busiest in the States and is serving several older adults every day. Next. We then joined the Age-Friendly Health System Spread Collaborative in 2024 with the aim of spreading age-friendly care to Doctors Community Hospital, which was now on board with the same EHR as the Anne Arundel Medical Center. And we're also looking to involve more of our outpatient and ambulatory settings to become truly an age-friendly health system. And so next, in the fall of 2024, the CMS measure was announced and found us in this journey where we were trying to become an age-friendly health system, and we're now working on the attestation measures as well. Next slide, please. The first thing that we did as a system was to look critically at all of the domains in the CMS measure. We almost immediately created a checklist, which was because we wanted to do 3 things. 1, we wanted to understand all of the elements within the domains as outlined in the CMS measure. It was important that we review every attestation statement and gain a good understanding of what is expected from us as a health system in order to fully attest that we were doing this work as required. The next goal of the checklist was that we would have a gap or a SWOT analysis to make sure that we can identify our strengths where we were already doing well since we had been on an age-friendly journey for a while. But we also wanted to note where we had opportunities for growth, for innovation, and for improvement, and to work on our areas of weakness so that we could meet the attestation accordingly. And finally, we wanted this checklist to be a basis from where we could start to monitor our progress along the journey. So how will we know when we can actually attest to each measure, and especially looking at the elements within each domain? Next slide, please. At the top of the slide, I show you a deeper dive into the elements of the checklist, and specifically under mentation. I did leave the ambulatory section in there just because we are working on a health system spread, but I want to draw your attention to the last three rows on that table at the top where you see the emergency department, inpatient, and ICU. And so this is our way of looking further into our checklist to ask ourselves that within each setting in the hospital, how are we assessing for delirium? Who is responsible for that assessment? How often do they do this assessment? And then more importantly, what do we do with the assessment? How are we acting on this assessment? Do we have protocols in place to respond to people with delirium? And then as we were doing the work, have also started working on a healthy aging dashboard where we can present our information in a way, in a linear manner, in a way that we can start to stratify data and analyze exactly how we're performing as we move along the journey. I also want to say that this work, as we all recognize, cannot be done by an individual. It really requires a multidisciplinary interfacility team when you have a system implementing it like we do. And we are very fortunate to have a multidisciplinary interfacility team that was already on board and working because had already started working on the spread collaborative work earlier in 2024. And so in our interfacility team, we have physicians, and this includes support from our hospitalist medical directors at both hospitals, nursing leadership from both facilities, representation from the other disciplines that work with us, and also informatics and analytics, without whom our healthy aging dashboard would not be a reality. And we have to underscore, like the previous speakers have done, that without executive leadership support, this work is not possible. And so one of the things that we have been fortunate to have is throughout our age-friendly journey is that executive leadership support right from the top. And this lends us strength and resources to do the work as we go on our journey. Next slide, please. So I wanted to start with this very exciting intervention in our emergency department. As I have already said, we are a very busy emergency department in the state, and we see about 30,000 older adults every year. And so it is important to start our interaction with the older adults coming into the hospital right at the beginning of their encounter with us, which is at the emergency department. The indicators that, or the attestation statements that we are required that fall under this are in domain 3, where we should be seen to have measures to reduce delirium in the emergency department and reducing length of stay. So how does this work? What we are targeting are older adults over the age of 65 who present to our emergency department and are potentially low acuity, even though they are high complexity just by virtue of their multiple chronic conditions. The goal is to triage them and fast-track them to a comprehensive geriatric evaluation using the 4Ms framework via telemedicine. And this will help us to really start to attend to the older adult within the first hour even of arrival in the emergency department, and see whether we can manage to turn that patient around and safely discharge them back to the community. So our goal is to reduce the length of stay in the ED, to facilitate early and safe discharge, and then to support them in the community by following up within those first 30 days and to see if we can reduce return to the ED in the first 7 or 30 days after discharge. We also know that not all of these adults will be discharged. And if they are admitted, we are going to be looking at the effect of that comprehensive geriatric evaluation on their length of stay in the hospital. And we're also going to be looking at the overall patient and family satisfaction. And so with this one exciting intervention, we are hoping to hit very many points on our CMS attestation, but also on longer term outcomes that are of interest in the care of older adults. Next slide, please. If a patient does get admitted to the hospital, how do the 4Ms work at Luminous Health? I thought that this whiteboard that is present in most of our patients' room is a great example of how we view the 4Ms practically on a day-to-day basis. So we have orientation and mentation right at the top, days of the week, the date, where you're located, what unit in the hospital. What matters is central to the care that we're providing to that older adult. And then we have a slot for medications and mobility, including mobility aids, as well as things like eyeglasses, hearing aids, and dentures, which we know are important in preventing delirium in older adults. And this whiteboard is a means of communication between patients and families and the interdisciplinary team, because everybody can see what is on that board and use the information to help provide better care. Next slide, please. What matters is really central to everything that we do in Anne Arundel and also at Doctors Community Hospital, but also for this attestation. What matters is really the cornerstone. In the interest of time, I will only tell you the story of the lady. This is a representation. This is not really my patient. This was an online photo, but I wanted to bring that story up because I think that the 4Ms really showed up in the care for the patient who I recently evaluated and was admitted for congestive heart failure. But what mattered most to this patient was that she was going to be a bridesmaid at her grandson's wedding. And her grandson's bride had graciously allowed her to walk down the aisle with her walker. So we were very excited to employ all of the 4Ms in her care to make sure that we appropriately dosed medications for her to be diuresed so that she wasn't short of breath, could walk down the aisle, could be able to participate in her grandson's wedding. And so I think this is why we do what we do. If we can align all of the healthcare for patients so that they can go back into the community and do what matters most to them. In terms of documentation, when a patient is admitted to the hospital, on our HMP, which is the admission document that the physician will use, the code status and advance directive are a hard stop. You have to indicate that you have reviewed the code status, you have reviewed the Maryland orders for life support, for life-sustaining treatment form. You have to indicate if you have also reviewed advanced directives. And you also have to answer the question when these documents were completed and with whom you discussed those documents and issues. And so this is a hard stop, and we begin to document what matters to patients in a very succinct and direct way as we provide care. Nurses will also document this in their intake and daily flow sheets. Next slide, please. So here we are, our patient is now in the emergency department, like I said, is where care in the hospital starts. We have a panel that we call the de-escalation order set. This is designed with mostly non-pharmacological interventions to help prevent delirium in the emergency department. Next. When the patient gets admitted to the hospital, every patient admitted, there is an inpatient order set, which caters either for observation patients or inpatient. And no matter which order set you use, the delirium prevention panel automatically populates if the patient is over the age of 65. And with one click, the delirium prevention panel shows up in the patient order set and again prioritizes non-pharmacological interventions. So another way in which we are practically addressing questions in the domain 3 of preventing, screening for delirium, preventing delirium, and documenting that appropriately. Next slide, please. On our healthy aging dashboard, we just go ahead and click so that the graphs can show, please. Thank you. So the first one is a BCAM assessment. So we use the brief confusion assessment method to assess for delirium. And here I just wanted to show you that we can show data on a daily basis. How many patients over the age of 65 are in the hospital? How many of them which is that number in the middle column where you see 272. How many of them received a BCAM assessment? Those two columns should have the same number. So already we can see that here about 88% of screening was done. And so we can then start to work with our units on the different floors to see what their barriers are to completing assessment. And then we also have in the column on the far left, where you can see the total count of BCAM, which tells you how many patients are delirious. So this is just to show you that you can collect data on a daily basis to show how screening and assessment is ongoing in the facility. Next click, please. And then on our healthy aging dashboard, we can see this on a month-to-month basis. And as you can see, we can look at data from either Anne Arundel Medical Center or from Doctors Community Hospital, as well as the system as a whole. So again, building this dashboard to help us look at data in individual hospitals as well as in across the system as a whole. Next, please. And here you can see the screening over time. And actually, the most recent data shows that we are up to 75% screening in our hospitals, which is really good. Next slide, please. And we're also interested in outcomes and impact. So what is the length of stay for patients, for example, with delirium and without delirium? And without going into too much detail, the difference in patients who have delirium, as you see in the lighter color, compared to those without delirium in the darker color, the difference in the length of stay is about 3 days. And just the cost of the room for those 3 days, the difference is about $750,000 a year without counting all of the other medical care they'll be receiving. And so we can immediately begin to see the impact of delirium and the necessity to have data that we can follow and that we can use to improve care and outcomes. Next slide, please. When it comes to medications, we're using EPIC as our EMR, and so the BS criteria is embedded, and so that gives us nudges or practice advisories on potentially inappropriate medications. We have moved away from the use of best practice advisories just because of the fatigue and not very good uptake from clinicians. So medications, we have that. And then next slide, we have a medication reconciliation project that is underway to help us evaluate medications when patients are admitted and to reconcile them in transitions of care within the hospital and also at discharge. Next slide, please. Then mobility is a very important thing. In the first quarter of this year, we focused a lot on mobility. We made sure that our order sets are now pro-mobility instead of just fall prevention. And our goal is to now evaluate how well we are moving patients from the time of admission to the time of discharge. And so if you can see in the upper right-hand corner, there is a graph with amber with some orange and green bars, and those show you mobility of a patient compared, the days they were mobilized compared to their total stay in the hospital. And our goal is to make sure that we are mobilizing patients 2 to 3 times a day so that they can maintain their function. Next slide. We're also screening for social isolation. This is a screenshot from EPIC, but I do want to say that our case management and social workers do a comprehensive evaluation of patients on intake and make sure that we understand how their functional status was before they came in, all of their social factors such as transportation, insurance, and so on, if they were on home health services, etc. And what we are now trying to understand is how we're going to meet the requirement to do that screening, not just on admission, but also on discharge. And I think that's a question outstanding for us to have a better understanding of how that works. We do a very good job on admission, but at discharge, I think that is still a work in progress. Next slide. And we want to make sure that we're taking care of our caregivers. And so, as you can see at the top, we make sure that we note who the caregivers are, who is important to the patient from a healthcare standpoint. We also want to specifically note all of this in Epic, and these are screenshots from our EHR. And then we have resources for our caregivers that we're distributing. They're present on our website. And this is our way of reaching out to caregivers without whom many of our patients will not continue to live and do what matters most to them in the community. Next slide, please. And finally, so moving forward, we want to see how we can evaluate patients for frailty outside of just the measures that we have been given, but also the frailty score, and because it's so relevant in geriatrics. So how are we doing? What are we doing with our data on nutrition, and how does that show up on our dashboard? That's an outstanding issue for us. Social determinants, as I have said, we are looking at how to do that better at discharge. And overall, we want to see how all of this work feeds into patient satisfaction and relevant outcomes such as readmission, length of stay, patients being discharged to institutions instead of home, and then overall morbidity and mortality. Thank you.
Thank you so much, Dr. Mwangi, and to all the presenters for that incredible background. And I will turn it over to our colleague at Patel, Aya, to lead us through the Q&A.
Thank you so much, Kellyanne, and thank you all for this wonderful presentation that's super informative. So our first question here is, what are the financial impacts of not responding to the age-friendly hospital measure?
I'll take that if I can.
Yeah.
Thanks so much. I'm going to frame this in a particular way as I dive into this question. First of all, we talk a lot about savings, shorter length of stay. We talk about no readmissions. And really, if you think about this measure, complying with the reporting on this particular measure is not about savings. It's actually on the other side. It's about revenue. It's about money coming in the door for your health system. And that is a very different way of thinking about it, and frankly, a powerful way for hospital administrators. Hospitals who are participating in the IQR program, which is basically all hospitals except for some critical access hospitals, have to report on the CMS age-friendly hospital measure in order to receive their full Medicare payment updates. Hospitals will receive the full update as long as they report on this measure and others in good faith. And hospitals that don't will face a penalty. And I'll be a little bit more specific. So the payments and reductions are set each year, so I can't give you an absolute, but the IQR measure updates, as they're called, are typically 2 to 3% of a hospital's Medicare spend. So we've gone to some of the estimates of the American College of Surgeons to give you a sense of what that actually looks like, what that means. They estimate that the penalty for not complying, so if you don't report, your hospital faces a reduction in your annual Medicare payment update, which would be an increase in payment. And let's say you're an 800-bed hospital. That amount that you would lose if you don't comply could be up to $3 million for a single year of not reporting on the measure. But an 800-bed hospital is a really big hospital. That is not your norm. If you're at a 186-bed hospital, they estimate that it's about $200,000. And even that's a little bit larger than average. A smaller hospital, even a 25-bed critical access hospital, that would be about $20,000. So hospitals are participating because they've got really thin margins already, and they do not want to leave any money on the table. And now they've got to report on age-friendly care as part of that process.
Wonderful. Thank you for that very detailed answer. We've got another question here. So can you clarify what population of patients is in the denominator for meeting the metrics of the CMS measures, age-friendly measures, as well as the IHI age-friendly standards?
You want to go ahead, Dr. Drago?
Yeah.
Yeah. So Great question. Well, first of all, I want to touch on a question that's probably coming that remember, this is an attestation measure, not a reporting measure. So we are not needing to submit actual performance data to CMS. So there is no denominator for this measure. The reporting is simply yes, we do this, or yes, we have policies, procedures, process to meet this statement within our best judgment and reason, or no, we don't have that. And this year there is no penalty for saying no. This is pay for reporting. Okay, I feel like this question is coming, Aya, so I'm just going to get out in front of it. But for those who are interested in becoming sort of formal, joining the age-friendly movement, becoming participants, and then committed to care excellence, data is, of course, a very important part of that process. The denominator for tracking performance, what we use at OHSU, what I'm sure Dr. Mwangi uses at Luminous, the overall denominator is every inpatient, admitted patient, 65 years and older, period. Remember, the magic of the 4Ms is that they are relevant to every older adult, every health status and state of health, every phase of life, every diagnosis. So we don't have to get much more complicated than that. This is a classic what's good for the goose situation. So when you're thinking about building your own data flows or thinking about just looking at current performance internally, remember, you don't have to report it to CMS just yet. We encourage you to take kind of a broad look and look across all inpatients that are 65 years and older.
Okay, and while I've got you on the spot here, I'll give you one more question, which is how is CMS going to measure if we actually meet the subdomain criteria for the 5 domains measures?
Yeah, I love being the deliverer of good news. That remember, this is a reporting measure. So in this current version, it is pay for reporting. It is not pay for data performance. There is no mechanism right now, knock on wood, that requires hospitals to submit actual data for verification by CMS. It is all of us, participating in the IQR, reading each of those statements and then attesting either, yes, we have reasonable policies, practices, standard work, whatever, to do this, or no, we do not. So there is an element of the honor system to this. In my simple brain, we have seen CMS start with measures like this that are, more attestation, pay for reporting, and then over time to give us time to sort of build up our systems, get things in place in a really meaningful and thoughtful way. It very well might turn into a reporting measure down the road. So I think, well, I can put this out there. I kind of hope it does. But for right now, there is no kind of backwards verification from CMS saying, how exactly are you meeting this domain? It's just pay for reporting, yes or no.
Awesome.
Ivy, you have your hand up. Do you want to contribute? I probably missed something.
No, you did not, Katie. It's a very comprehensive answer. You literally took the words out of my mouth. But I did want to say that part of why we were showing our age-friendly, our healthy aging dashboard and how we are drilling into each M to figure out how exactly are we doing it, who is doing it, what tools are we using, where are we documenting this, how are we measuring it, is in order to prepare ourselves in the event that somebody does come by and say, so you said you were doing this, can you show us how? And we want to be able to meaningfully attest to the measure. So while we might not be scrutinized now, this is the time to build up all of the systems and the SOPs and the policies that you need to be ready at the time when it will be time to show exactly how you are providing the 4Ms care in our system. And so this is a good opportunity to build that up as we think about the measure going forward.
Thank you so much for this answer. And thank you everyone for all these wonderful questions. We are at time. Again, the meeting materials will be posted on the MMS Hub website in the coming weeks, and we can go to the next slide. As a reminder, just as always, visit the MMS Hub for all upcoming events and opportunities, or reach out to mmssupport@battelle.org. Thank you again to our presenters. Thank you to this fantastic audience for attending today's session. Have a wonderful rest of the week.